Thanks very much. So I would like to take you through some work on an integrated transition model for maternal, late fetal, and newborn mortality with a strong focus on low and middle income countries. So I'll first talk a little bit about the context, which is an exemplar study in maternal and newborn health that we're currently conducting. Talk about transition models that are out there for population mortality and then for maternal stillbirth and neonatal mortality. And then critically look at what's the evidence of such a transition for maternal and newborn health in terms of causes of death, inequalities, fertility, and service delivery. So first, the maternal and newborn health exemplar study that we're working on right now as a countdown to 2030 for women and children's and adolescents health, which is in collaboration of academic institutions with WHO and UNICEF. And in this particular study, we work with Una Campbell and her team from the London School of Hygiene and Tropical Medicine and Agbezi Amuzu from Johns Hopkins University. So we have selected 7 countries which have had greater success than it could be expected based on their economic progress over the last 2 decades to try to understand better the drivers of rapid progress. And drivers, we mean government, things that the government did, but also things in terms of introduction of interventions, how this was done, but and also contextual progress. So these countries are 3 in Africa, Ethiopia, Niger, and Senegal, 3 in South Asia, Bangladesh, India, and Nepal, and then Morocco in North Africa. And I'll use some of the examples of this work, but it's really what stimulated us to think hard about this transition. Just one more general point, maternal and newborn in global health. Of course, it's still, a priority area with about 300,000 maternal deaths every year, 2 million stillbirths, and an estimated 2.4 million neonatal deaths. So together coming close to 5 million deaths a year, which is still almost 10% of deaths in the world every year. There's been a lot of research and calls to actions since 2000. Initially, it started all with Alan Rosenfield in the 80s with sort of where's the M in MTH, and then so where's the N in MNCH, the neonatal survival. So in 2005, led by Joe Lawn from London School, a fantastic series on neonatal survival. But then later on, of course, also stillbirth got more attention as a sort of neglected topic in global health. There have been multiple global initiatives, and they usually focused on one of the 3 areas: maternal, newborn, stillbirth. And unfortunately, there's this ghastly acronym RMNCAH and nutrition, and some want to add another S of sexual and reproductive health, maternal, newborn, child, adolescent health and nutrition. And one of the criteria for working in this field is whether you can say that acronym really fast. But frankly, it is a symptom of fragmentation that we don't need. And I hope I can make that point also in this presentation. Now, in the exemplars, our approach is basically to cut across maternal and newborn health and use a common conceptual framework to identify drivers of change in maternal, late fetal, and newborn mortality. And secondly, using a common mortality transition model. So what I'm going to talk about is that second point. I won't talk about the conceptual framework that we use here. So the transition model. Well, I sort of assume that most of you are very familiar with the transition models that are very well known. The demographic transition from high mortality and fertility to low mortality and fertility, where the mortality decline precedes the fertility decline and gives rise to enormous population growth. And the epidemiological transition, Abdel Omran, cause-specific mortality changes from predominance of infections and malnutrition to NCDs, degenerative diseases, as he calls it. And this model has been used a lot, both the demographic and the epidemiological transitions. The strength, or it's useful for predictions. It contributes to developing intervention strategies. It's also useful to identify common patterns, but also deviations of it. And there's been quite a bit of critique on it as well, because the models are based on historical data from today's high-income countries and perhaps not so applicable to today's low middle and income countries, where the mortality transition is much faster. And there's considerable heterogeneity in the transitions in terms of timing and pace of the transition. And Julio Frenk sort of called this, there are protracted polarized transitions within a country, which sort of undermine the assumptions of the model. So inequalities within countries are not considered inadequate. Now, within maternal and newborn health, there are also similar kinds of approaches. So there's an obstetric transition model, which was proposed in 2014 by Souza and colleagues. In fact, there was a precursor about 10 years earlier, which I didn't mention, but the maternal mortality transition was mentioned in a World Bank report. 4 phases in which maternal mortality goes from high to low, skilled birth attendance from low to high, and each phase gradually merges into the next. Souza and colleagues, however, put some quantitative thresholds on it, which we think is very useful. So they put the thresholds at 1,000 per 100,000 live births, which is very high mortality, then 300, and then 50 per 100,000 live birth. And for stage 5, which is when there is no more avoidable mortality, no thresholds was put. So what this graph shows on the right is basically the blue dots are all countries, and this is the level of maternal mortality in 2000, and the red dots are the level of mortality in 2017. So we see that there were quite a few countries in the top stage, but then very few going from stage 2 to 3 and sort of moving down, and I'll come back to that. The framework was applied, the model was applied to the 2010-11 WHO hospital-based multi-country study on maternal, newborn, perinatal health in 29 countries. And the countries were classified into these stages of mortality transition. And what they showed was, for instance, that there were major differences in the hospital maternal mortality ratio, in the fertility going down, the C-section rates, the rates of induced labor, and also the age of the woman going up, and then ruptured uterus, which was used as a tracer complication, was going down considerably. Now, in stillbirth and neonatal mortality, there is no formal proposition for a transition model, but work by Joy Long and colleagues published in The Lancet in 2005 made a major step forward, because they used thresholds to classify low and middle income countries based on the level of neonatal mortality. So they had 4 groups where neonatal mortality was less than 15, 15 to 30, 30 to 45, and then greater than 45 per 1,000 live birth. And it showed, they showed how estimated distributions of causes of death and coverage and so on varied quite a lot by level of mortality. And that approach was expanded in 2014 in the Lancet series. The higher cutoff was dropped because there were few countries in that group at that time. And this kind of classification was then used to also look at care packages and how they would function at and perform at different levels of mortality. Now, towards an integrated transition model for maternal, late fetal, and newborn mortality is what we were looking for. So does a single model for all 3 target groups make sense? Can we identify thresholds for a stage transition with mortality levels like the others have done? And then is this mortality transition meaningful and linked to shifts in terms of for maternal, stillbirth, and neonatal mortality in terms of causes of death, inequalities in survival and care, fertility, coverage of interventions, and how do socioeconomic changes factor in? And I already have to say, I'm not going to address that. So when we look at going to look at the evidence, we consider two types of evidence. One is historical trend data to define thresholds for stages and look for associations, and then cross-sectional data from low and middle income countries, particularly for the last 20 years or so. So in the model, we will propose sort of these cutoffs very much linked to what you saw earlier related to the obstetric transition and what the neonatal mortality group proposed. But we combine stillbirth and neonatal mortality into one measure per 1,000 births. So at stage 1, which is the highest mortality level, maternal mortalities are over 800 per 100,000 live birth, whereas stillbirth plus neonatal mortality is over 80 per 1,000 births. And the stage transition is only made if both targets are met. The third group is actually the SDG, the Sustainable Development Goal targets, so which is globally set at 70 for individual countries, 50 may be better, but also the stillbirth and neonatal mortality targets are 12. There's one Sustainable Development Goal target for neonatal mortality, and the stillbirth target of 12 is from the Every Newborn Action Plan. So these are sort of the stages we propose. So this graph maps on the y-axis maternal mortality per 100,000 live births, going from 0 to over 1,000, and on the x-axis stillbirth and neonatal mortality combined per 1,000 births. This should not be live births, apologize for that, per 1,000 births. And the dotted lines are the thresholds that we propose for a mortality transition. The dots are countries based on UN estimates for the year 2000, made just recently. And the countries with the names in orange are exemplar countries. So now I'm going to animate this graph and show you how this situation changed in the next 17 years. So we see a massive decline in both maternal and stillbirth and neonatal mortality, and many countries move into the next stage, from 1 to 2, from 2 to 3, and from 3 to 4. And 4 is when the SDG targets have been met. We also looked at this for the transition for the exemplar countries. And for instance, you can see that Ethiopia moved from stage 1 to a late stage 2, an enormous decline. Bangladesh hadn't even reached stage 2 for both targets because of the high stillbirth neonatal mortality, but then enormous progress into sort of almost the middle of stage 3. India moving here. Morocco is within stage 3 and is pushing against, this is the SDG target point of 24 stillbirth neonatal and 70 others. So this insert is actually showing India divided into higher and lower mortality states. And this is really policy relevant information to contextualize what is being done. So what, and I'll come back to that later, but what India succeeded in was built up of sort of two components, if one wants to simplify, for such a huge country. High mortality states, which is about half of the population, moved from very high stage 2 to 1 even, to deep into stage 3, but then the lower mortality states kept on pushing on and are now close to the Sustainable Development targets. And there are marked differences in the kind of strategies that were used to make this kind of progress. So let's try to see how meaningful these thresholds are based on historical data first, and then also about current data. So if we look at maternal mortality, much of the historical data comes from today's high-income countries, Europe, North America, and informs the obstetric transition model. There were major differences between countries pre-1936-37. Successful countries, Scandinavian countries, the Netherlands, which had levels of about 300 per 100,000. And this is per 10,000 in this graph, which I borrowed from paper by De Brouwer. But successful with system of midwifery and antiseptic measures, which contrasts sharply with England and Wales and other countries, but particularly also the US, where there was really interventionist obstetrics that didn't do the women much good because levels were around 700 to 800. Then Sri Lanka and Malaysia are two exceptions that overcome the sort of lack of data in low and middle income countries and have good time series. So up here, there's Malaysia, which had levels above 1,000. So this is stage 1, but then really comes down very strong, first by increasing access and then later quality, to levels of about 300, which is our transition from stage 2 to 3 by 1960, and to about 50, which was SDGs met by 1980. And Sri Lanka was even higher with levels around 2,000, enormously high mortality of mothers, but then coming down also very strongly, and also by 1960 reaching that level of 300, which the high-income countries had by 1900 to 1930, by this group of countries. The convergence occurs after the introduction of antibiotics and sulfonamides, but also many other interventions may have played a role. So if we look at maternal mortality in low and middle income countries, it's one of the most difficult to measure indicators because we have very few data points. We rely on household surveys where questions are asked about the survival of the sisters and brothers, but the sisters are relevant here. This is not a very good method, but it's all we got because there is no good death registration system. So global models actually use covariates like fertility and stillbirth attendance to sort of get a reasonable estimate of maternal mortality. There's been a major decline globally and everywhere since 2000. Many countries are now between 300 and 700, which would be a stage 2, mostly in sub-Saharan Africa. But then also many countries are in stage 3, which have moved to levels below 300. Now, stillbirth, historically, levels have been documented between 40 and 70 per 1,000 births in the 19th century. But from 1900 to 1940, and data are probably also a bit better, the levels for quite a few countries, and here I'm showing the Scandinavian countries, and up here this is England and Wales, but also Canada and Netherlands and others, have sort of hovered between 20 and 30, 25 and 30 per 1,000 live births, per 1,000 births, and then a decline starts after that to 10 to 10 around 1980 and further down. Now, low-income countries, low and middle-income countries have poor data because they have poor death registration, the same reasons as maternal mortality. Hospital data cannot really be trusted, although major efforts are ongoing to improve that now. So a global model to estimate stillbirth has to use all sorts of covariates to get a reasonable estimate. And one of those covariates is neonatal mortality. So there is some reverse causality in our analysis, which I will mention if that occurs. But there has been a major decline in stillbirth rates according to what we have, but they're still far from the target of 12 per 1,000 by 2030, except for sub-Saharan Africa, especially in sub-Saharan Africa and South Asia. Now, if we look at neonatal mortality, it's actually surprised me a bit how little there is on neonatal mortality compared to how much there is on infant mortality trends in the today's high-income countries. And it's sort of neglected. It's buried under infant mortality. And that's why a major push was needed to draw more attention to neonatal mortality in at least the measurement field. But levels of 30 to 45 were common in the 1920s to 1930s in the high-income countries. We've got evidence of major declines in Sri Lanka and in Malaysia, as shown on the right. But also the estimates for low and middle income countries from 1960 show that quite high levels of neonatal mortality, well above 50 per thousand, particularly in Asia. Now, the current trends are also going down, maybe not as fast as under 5 mortality, but even in sub-Saharan Africa and South Central Asia, it declined from 40 per thousand to 25 per thousand live birth, which is still quite far from the target, but is a positive trend. So if we think about stillbirth and neonatal mortality rates, I think there's a strong argument for combining them into one measure. Of course, perinatal mortality does that for the first week mortality after birth and the stillbirth. In fact, but our perinatal mortality rates seem to be used much less, and I think there is a case for it to combine either stillbirth and first week neonatal mortality rates, or stillbirth and neonatal mortality for the whole first month, as we've done here. The levels are highly correlated. We looked at longitudinal studies where pregnant women are followed all the way through. The ratio was about 0.8 in low middle income countries, so 0.8 stillbirth for 1 neonatal death. And also global estimates are highly correlated, as we see in this graph on the right, where we have neonatal mortality on the y-axis and stillbirth mortality here. But in part, this is where we have to be careful, of course, because the global estimates of stillbirth use also neonatal mortality as one of the covariates. And then, of course, in the terms of the timing of death, most deaths cluster around labor and within 24 hours after delivery. 40 to 50% of maternal death, more than 40% of stillbirth and neonatal death. So an integrated approach for stillbirth and neonatal death, but also maternal death. The diet approach, mother-baby, addressing this period of very high risk is essential. So I've sort of now tried to sort of underpin the numerical estimates for these thresholds that we use in the stages. And so now let's see how this works on a number of critical facts, such as causes of death. So causes of death, if we go by the epidemiological transition, we would see a major decline in infectious diseases and also perhaps nutritional status, as many have argued. And so we created 3 cause groups from the maternal, stillbirth, and neonatal causes. One around infections, which includes unsafe abortion. One around peripartum causes, which is delivery complications, intrapartum causes. And one around maternal, fetal, and newborn health status, which includes NCDs, but also low birth weight, prematurity, hypertensive disorders such as eclampsia. And sort of this hypothetical change over time as the stages progress would show then a major decline in infectious diseases, some decline in peripartum conditions, but an increase in the relative importance of underlying maternal newborn health status, and then other conditions becoming more important as well. So what's the evidence for this? In terms of causes of maternal death, main causes are infections, sepsis, hemorrhage, hypertensive disorders, abortion complications, and indirect causes, according to WHO estimates. The decline is driven by all 4 obstetric causes, but especially infections and abortion complications. I think that there's evidence for that. But there's an increasing importance of indirect causes as the transition progresses, so non-obstetric. The historical data support that to some extent, as you would expect. The graph here from England and Wales shows that in the second half of the 1930s, there was a massive decline in puerperal sepsis and septic abortions. Also data from Sri Lanka over the last 40 years, 1940, 1980, show that as the levels declined from very high stage 1 to stage 3, where it's below 300 maternal mortality, there were major declines in infections and hypertensive disease, eclampsia, followed by hemorrhage. And possibly also malaria played a major role here. And we see the increase of the relative importance of other conditions. Unfortunately, we don't have very reliable data on causes of maternal death from low and middle income countries, which is really sad to report. And global estimates, however, don't seem to provide very strong evidence for this kind of transition, except a decrease in obstetric causes and an increase in indirect causes. And this may have to do with a sort of different situation around infections, which is sort of the low-hanging fruit that have been tackled even before 2000. If we think about causes of stillbirth and neonatal mortality, the transition evidence for stillbirth is there are limited data, as we would expect, but over 40% of global stillbirths are estimated to be intrapartum, and that proportion is declining as levels of mortality fall. Infections, NCDs, maternal health status, and other things are also important causes of stillbirth, but we cannot really, we don't really have a lot of evidence to show how that transitions as we move through the different stages. Neonatal mortality is a kind of interesting because preterm birth complications, which sort of have similar proportions in low and high mortality countries, have a much smaller reduction than the other causes, which increases their relative share, whereas intrapartum complications and infections which are very common at high levels of mortality, decrease quite a lot. And here's an example showing those levels of mortality. 45 was the high mortality where infections are really predominant. And then if you move all the way to 15 or lower, you see that these other conditions are very critical. So that's about causes of death. So some evidence, but there are also some weaknesses in sort of the transition. Is definitely not a smooth epidemiological transition as the epidemiological transition theory puts forward. Now, inequality patterns. So inequality patterns, which have not been really taken much into account in the other transition theories, I think deserve some special attention here, because I was very inspired by what a friend of mine did, Cesar Victora, at the Federal University of Pelotas, in terms of inequalities. So he basically took institutional deliveries to prove that there was an inverse equity hypothesis, meaning new intervention comes, is first adopted by the richest, then it sort of spreads out, and then the poorest are left behind. So what these 5 balls show is basically the coverage of delivery in institutions by wealth quintile. So these are the richest on the right, the yellow, and the poorest are on the left. So what we see at very high levels, very low levels of coverage is that all these have very low coverage with institutional delivery, less than 30%. But only the rich are standing out. And this is what is called top inequality, or kind of mass deprivation. All of those are deprived from the services. And that slowly transitions into a linear pattern. And then when we come to high levels of coverage, it's that poorest group that's left behind. And so this is where there is marginalization of the poor, and much needs to be done to really pull them in to get universal coverage. So what's the evidence for these inequality patterns for mortality? Because this was coverage. So there are very limited data for maternal mortality that disaggregate, because it's relatively rare and there is simply not good data. There is, however, some from India and China from their surveillance system and sample registration system, which shows trends over time. I just showed the trend in India in the upper slide, which is in the middle, India, maternal mortality decline from over 300 to less than about 100. These are the higher mortality states, these are the lower mortality states. And so there's a huge gap between those states in terms of maternal mortality. And even though it comes closer, but the relative gap stays very much the same. So there isn't really much progress and in terms of inequalities. And the same is what the China data show. Also, as I indicated earlier, we measure in most countries maternal mortality through these sibling survival histories, questions to the respondent about the survival of the sisters. But these samples are usually not big enough to look at inequalities, except in Bangladesh, where they do the huge surveys because they've really made maternal mortality reduction a political issue. And they have 300,000 household surveys that allow us to disaggregate. We disaggregate those, but in fact, the patterns that show all the way on the right were not really very clear in terms of the inequalities that we were expecting, except in the most recent survey where at least the top was ahead of the bottom 3 quintiles. Also, in terms of stillbirth and neonatal mortality rates, I think we don't have strong evidence of this kind of inequality happening for mortality. For stillbirth, historically, it seems that was less influenced by poverty and family size than infant mortality. But there's a lack of data. For neonatal mortality, we can look. And so just to take one example, Cambodia. So these are the 5 wealth quintiles from the poorest to the richest. These are 3 surveys, the oldest and the latest. Neonatal mortality is declining from 39 to 21. So what we see with the blue line is what is a pattern of top inequality. Only the richest have an advantage. And then it goes to linear, where there is inequality, but it's not a certain pattern. Now we see this in some countries, but overall, I think it's not enough. And maybe that's also because of the wealth indicators that we use that is not detailed enough. Maybe it's not the poorest 20% that's left behind, maybe the poorest 10%, or maybe some other characteristics like race, ethnicity define how far one is left behind. The next one is fertility. So the different options in a transition model are that the fertility decline precedes mortality decline. So family planning needs to pick up first, better nutritional status of women, etc. Or fertility decline is concomitant to a mortality decline, where I say a health system delivers all interventions, overall development. Or the fertility decline follows the mortality decline, like it's in the demographic transition. Women, couples first need to know that their children can survive before they reduce their fertility. Now, in terms of historical data from Sri Lanka and Malaysia, we know that maternal mortality can decline below 300, so that's into stage 3, without changes in fertility. When Malaysia or Sri Lanka in 1960 reached that stage, total fertility was 5 to 6 children per woman. But if we look at the total fertility changes in the lower graph, and these are the boxes, so this is the median, this line, we see that the total number of children, the total fertility rate drops drastically, particularly between stage 2 and 3. So going and pushing towards those SDGs is where a major fertility reduction is happening. So here we see that in today's low and middle income countries for 2000 and 2017, basically the same situation between, there's a major fertility difference going from stage 2 to 3, the middle 2 boxes, a greater difference in 2017 than 2000, but there's also quite some heterogeneity in terms of which countries that do have a fertility decline and countries that do not. We looked at this a little bit closer for our exemplar countries. And all these 7 countries had major fertility declines during the 90s and before, except Niger. For the Asian countries, I think the fertility decline was particularly part of a longer-term decline that some already started in the 60s and then sort of accelerated. And the neonatal mortality decline, as shown in sort of the India graphs, sort of seemed to occur concurrently, and this is from 1970. But in the sub-Saharan African countries, at least in Ethiopia and Senegal, there seems to be the neonatal mortality decline occurred before the fertility decline. So there was some of that, perhaps some of that effect, because about 10, 15 years earlier, that may have contributed to more women accepting family planning services and so on. Fertility is an important thing in the maternal and newborn mortality reduction, not only because there are fewer babies and fewer deliveries, but also because the risk distribution changes. So fewer babies are born to very young mothers or of very high birth order, which are both risk factors. So we applied the Jane method to sort of look at our 7 countries to see how much this had contributed to the mortality reduction in terms of neonatal and maternal mortality. And so the middle countries are the countries that moved from stage 2 to stage 3. So we see huge reductions in the 3 Asian countries, much less so in Senegal, where the fertility decline was much smaller. Also quite big in Morocco, but Morocco was already at 2.4 for children per woman in 2000, so it could never be that big as these countries. And then nothing happening really in Niger, but Ethiopia did actually have a fertility decline, as we saw, that contributed to these reductions. So it is a very critical factor. The last one is on service delivery. Just dug up some Canadian data on institutional delivery. And these are data from Canada from 1926 to 1974. And we have percent of birth in hospitals on the x-axis. We have maternal mortality over here and neonatal mortality over there, the red dots, and the blue dots are maternal mortality. And it actually fits almost perfect in the transition model as we've sketched it. Around 1943, 1944, Canada transitioned from stage 2 to stage 3 with a maternal mortality of 300 passing through that and a stillbirth rate of 53. And so that's just happening here. And then it transitioned from stage 3 to 4. Sorry, I forgot to say, and that happened with about half of the birth in hospitals. And then over here, the second circle indicates the transition from 3 to 4. So this is where the sustainable development targets are met, around 50 to 70 maternal mortality and 35 or so stillbirth and neonatal mortality. And this happened around 1955. So yeah, this is a nice application, in my view, of the transition theory that this actually occurs, but it also was accompanied by an enormous increase in deliveries in health facilities. And all the way to the right is the further decreasing to, say, no more avoidable mortality. And that goes with almost 100% institutional deliveries. This is coverage in neonatal mortality, showing the different mortality levels. So the blue are the lowest mortality countries and the yellow are the highest mortality countries. And what's interesting here, of course, we expect increase in stillbirth attendance and institutional deliveries, and on the right, C-section rates. But what's quite dramatic is a sort of access to neonatal intensive care unit and specialized baby care unit over here. Almost none at levels above 15 neonatal mortality, and then pretty much universal at this lower level of mortalities, indicative of the role that sort of higher levels of technology are needed to go beyond 15. Now, if you look at the low and middle income countries, and sorry, this is yet another 4 graphs. By now, you must be dizzy of all the graphs that I'm showing. But basically, it shows the major increase in institutional deliveries here on the left with these from sort of 30% to 60% from going from stage 1 to 2, and then sort of flattening out. But that's and for cesarean section, it's more when further into the transition, going from 0.5% to 2%. And with these indicators, as we did with the exemplar countries, it's very useful to look at, say, the C-section rates among the poorest, which in Ethiopia and Niger are almost non-existent, was 0.1% in 2000 and just 1% or so in 17 years later. But then if we look at Morocco, Bangladesh is a country that relies very much on C-sections, but also in others, there's a major increase also among the poorest, or in terms of contents of care, in this case, blood sample taken. It's one of the few questions we have in surveys to look at contents of care. Now, I referred earlier to India, what has happened over the past 3 decades. And I think this is an important slide in terms of implications of the model for what needs to be done. So India increased its institutional deliveries from about 20%, hospital deliveries from about 20% in 1990 to almost 60% or 50% in 2015. Birth in community health centers and other lower level facilities started to increase because there was a major push for women to come to health facilities, and it increased to over 30% nationally. So home birth plunged down. Now, if we look at that in terms of the higher and lower mortality states, there's a big difference between the two. So on the left, the higher mortality states, the red line shows that hospital deliveries went up quite a bit to almost 30%, but it was particularly those lower level facility deliveries that pushed up the coverage of birth in institutions. And these lower level facilities can provide routine delivery care and sometimes basic emergency obstetric care, but they can't do C-sections or blood transfusions or more sophisticated things around neonatal survival. Now, the lower mortality states went up from under 40% in hospitals to 75% in hospitals, the graph here on the right. And the increase was only modest in smaller facilities. So it's basically relying, while moving from stage 2 to late stage 3, pushing against those SDGs on hospital birth. And these are facilities where the chances of comprehensive emergency obstetric care are much greater, like C-sections and so on. And this is a point that's been made by Una Campbell in the Lancet series in 2006, and also by Margaret Kruk in a recent paper, that there are actually some wrong decisions being made in countries which is really pushing women into lower level facilities, while the mortality levels are already into advanced stages. They really need to be at facilities that can provide these high level services, and referral systems would be a solution. If not, they don't have a strong track record, and also it does take a small country to be successful in that.
Thies, can I ask you to just 2 or 3 minutes so that we have time for questions?
I think this is my one last. So yeah, this is an application of the model trying to bring together antenatal delivery care and postnatal care in terms of a single index. One can look at equity that way, so I think that is okay. So in conclusion then, the obstetric transition model and the neonatal mortality classifications that have been published can be extended into a combined transition model with 5 phases and thresholds for stage transitions. It's useful to interpret country and subnational trends, define strategies, and identify outlying patterns. Many countries in stage 2 are in Africa, and most other low middle income countries in stage 3, early stage 3 by 2017. And we think that further refinement is needed to specify intervention strategies. like an early and late stage 3. In terms of causes of death, we've seen some evidence of major shifts in cause groups in line with the epidemiological transition, but more complex. It's more complex for maternal newborn health because of peripartum complications and prematurity, low birth weight. Inequality patterns, strong patterns in transition for coverage of delivery care. And with implications for delivery strategies, because if you have to address mass deprivation or marginalization is a completely different strategy. But data are less clear about changing patterns in inequality for mortality. Fertility moving into stage 2 was possible without any fertility change, but going beyond seems to be impossible without fertility decline. And there's some evidence from Africa that there is a mortality decline occurring before the fertility decline, but not in the Asian countries. Service provision, I think the coverage indicator analysis by stages is very useful. We need to focus more on disaggregated indicators and the quality of care dimension. Placement delivery, I think, is an important stratification between hospitals and lower level facilities. Limitations, there are many. One, I think that we didn't come up with a formal quantitative approach to determine the thresholds. We use sometimes circular arguments emanating from use of global estimates with their covariates. We consider mortality only, not mortality and morbidity and development. Quality of care is still very hard to measure on a large scale, and we did not consider socioeconomic changes in this phase. Sorry, I hope I haven't gone over too much. Thank you very much.